Hello, guys. My name is Richard Ogachi. This is my YouTube channel, and gonna thank you guys for following my channel and thank you for subscribing to my channel. And I looking forward to make some good content for you guys. And I believe that this is gonna help. It's gonna influence. It's gonna like uh, make impact and actually make everything out clear and see what happens and what we can do and how this can benefit people who are looking for services, and maybe you can get to make a decision based on your experiences. So welcome to this video. Welcome to my YouTube channel. For those who don't know me, I'm Richard Ogachi, a registered nurse. Been a registered nurse for the last now 16 years. I started nursing in Kenya many years ago, and it's been a journey for me, and it's been good experiences, and I can comfortably say that nursing is good, and especially now I'm a man, and I having a registered nurse as a man also is a different kind of situation, because also we not had over the years many nurses being men. So there are specific also now like issues that you go through as a nurse, as a man. And of course I'll try to cover that also in a different kind of video, like um my life as a male nurse, because we'll talk about that later. But today I'm here to specifically talk about now. We're looking at the differences in scope of practice in the United States of America and Kenya. So I'm here tonight or today to talk about the scope of practice, the scope of practice. So the scope of practice in the sense that we have um, the specific kind of roles, responsibilities, and what you can do. To what extent, what are the limitations on your type of cadre or your type of position as a registered nurse? So I wanted to talk about the scope in the context of Kenya, and that's where I did most of my nursing. And then also I look at the contrast with what happens or goes on in the US. So in Africa, to give context, I think mostly I can say issues. Most of the scope and practice is based on the rule of law, where my observation is the rule of law in developing countries is not as trailblazing as the US. So in the US, the scope or the rule of law is works, and it trailblazing. Like you can go for litigation in a court of law, and you have your case processed, and the process gone through the process, and you get to get a hearing, and of course maybe a sentencing or whatever happens after the or proven until proven guilty, you taken through the process through maybe acquiring a lawyer or just going alone to go to have your case heard in a court of law. And I think pretty much most people in the US get their cases or issues prosecuted, and justice either delivered or not delivered within good timelines. Of course, we have different kind of cases where that take so long and they delay. There is a sluggishness in courts of law. Of course, we understand there may be gaps in the system where people may have their justice delayed, But when we talk about those processes in Kenya or in Africa, generally speaking, is the litigation process is a long process and it takes time. And that, I think, also is where we have the window for the scope of practice, in the sense that we have registered nurses in Kenya. You know what a nurse can do. Like, you administer medications, we do administer medications and formulate nursing care plans for patients, and also take orders and give medications. Those are orders given by doctors most of the time. And I usually like talk about public health care because that's where most of the people go for health uh, checkups or treatment. So in government facilities, for example, the layout is in different levels, where we have level 6 until level 2, which is the lowest, and these are community health dispensaries or community health centers. Either most dispensaries, the lowest level 2, they have most of them are run by registered nurses, and they have different kind of they offer a spectrum of services, including curative and treatment. We have programs in the sense that we have HIV and AIDS programs where they do administer medications, TB programs, nutrition programs. We have immunization programs. We have where we have the administration of vaccines in using the national immunization schedule. We have also like lab. They have a small lab. So they are mostly run by registered nurses who are the facility charges. They do everything to run the facility. You have one of the registered nurse as a charge nurse who does like procurement of medical supplies and medicines, and they do budgeting, or like they do everything, including maintenance of the buildings. That's procurement of supplies or materials, and also like giving like orientation for the new incoming staff. That small level, we have the level 3 facilities. We have the level 3 and A and B. Those are health centers which are bigger than dispensaries, and they have different also cadre of staff. We in most dispensaries also we have like clinical officers and nurses also. They are bigger, and they have also a spectrum of services. And also you find that the health centers, you have find the charges are mostly clinical officers, but we also have registered nurses being charges in these facilities. So, and level 4 are sub-county hospitals that are bigger. They're headed by, maybe they also have like maybe one medical doctor or two who are charged in those hospitals. And then also we have level 5 and level 6. So in Kenya, or Kenyan healthcare system, especially government hospitals, we have registered nurses in the level 3 and level 2 facilities doing uh, more than what is their scope. You find they are giving scripts to patients. They see patients in the outpatient clinics. They see patients, and they give scripts, they give treatment, they give prescriptions, and they also treat patients who come. Uh, some of the dispensaries also, like, they only have maybe one or two nurses who do everything for the patients. You see a patient in the outpatient department, they come, they have a cut on their head or whatever it is. They do the suturing, they prescribe medications, they do first aid management, either by doing the controlling the bleeding, they administer the medications, they move, or they either, if it's severe, they refer them to the next level. But in the level 3 and below, the registered nurses also go do a lot of work and a lot of work that is out of their scope. We, like most of them, those that are far away from the cities, you find the registered nurse is the one who does the writing of prescriptions, they administer the medication, they even do the labs sometimes, like the random tests like HIV or checking of the HB using the strips, the test strips, and the rest of the others, just because, of course, of having lesser staff, or they don't have enough staff to cover and see patients at that level. So you find that sometimes even they have like a maternity facility, which is mostly health centers. They have the registered nurses or midwives. They deliver pregnant women and they do everything for them. And the doctors also now carry on from maybe these mothers have complications. The nurses always handle them. Like, for example, we have prolapse cord, we have postpartum hemorrhage, PPH, we have fetal distress, we have maybe obstructed labor, breech presentation or uh, malpresentation. You find some of the registered nurses at those levels, they are so good and they do everything. They cover and like help. It's actually helping at those levels, because otherwise, the patients won't get the care that they're looking for. Either the facilities are too far away from their homes, or maybe they don't have the money to go and access healthcare uh, in the hospital or big hospitals, or the hospitals that have all the resources to manage their conditions. So when you look at now, having done that, because I also worked in those facilities and did everything from writing prescriptions for patients, doing algorithms for example, STI and UTIs, because and IMCI, that's management of childhood illnesses. You find that they are good programs because they help in resource strained or resource where there are no enough resources to test or to give care. Like, for example, the best of the programs I like in resource strained areas is integrated or management of childhood illnesses algorithms. They have charts. They use the charts to manage childhood conditions. For example, patients or children under the age of 5 years who come to outpatient clinics, they use the algorithm to treat either upper respiratory infections. They treat otitis media. They use the algorithm to decide if they're going to give IV fluids. That's severe dehydration. They have classifications of moderate to severe or mild dehydration. They have algorithm on how to manage those conditions. They have also the whole chart shows which antibiotics you give. You look at the clinical features the kids are or the children are presenting with. For example, if you have a child who has cough, they have what we call danger signs. Danger signs in children at the age of 5 years includes either the child has fever, the child has is not eating. That's either the child is having severe dehydration or they are vomiting everything. You find, or they are non-responsive. Using those algorithms only, the registered nurses can administer treatment. I like that because that can be used anywhere. Because when it's just like when you do BLS, for example, basic life support, they have an algorithm on what action you do when you have when you're doing CPR or ACLS. They also have an algorithm on what you do. Those are kind of the same principle. They use a chart to treat the childhood illnesses. We also have charts to treat STI and UTIs. They have clinical features, specific clinical features you have to look for, and then decide what test can do if you have access, or what antibiotics, or what referral system you can also have an option of referral, just in case it's a complicated case or clinical condition. So that is the background of practice in the Kenyan system. When you come and practice in the US, the nurses, the registered nurses have specific practice. I call it resource abundance. There is no as much improvisation in the US because you have everything you need. You can become effective as a registered nurse because you have all the medications available. You don't have like situations where you are not getting the treatment or the drugs or the medicines. You have all the supplies, either non-pharmaceuticals, you have everything, and medical supplies, they have everything. Let me give an example of a situation I was in or I've been in. That's why I usually talk about when you really want to change, or when you've done something for a long time, it's going to be so hard for you to change. It's usually very difficult to provoke change within yourself. When I talk about this, I give the perfect example of when I was practicing in Kenya, most of the time working in a hospital, government facilities. We used tourniquet. We used gloves as tourniquet. You just pull a glove and tie on the arm of the patient and put in the IVs. So in the US, that's a simple, basic observation or example I want to give, because I've really struggled with that. So I got so used that you pull the glove and tie the arm and put in the IV. But when I got here, when you're putting an IV, they have a pack that has everything inside, that has the whole set. Has a pair of gloves, it has a tourniquet, it has gauzes, and it has a gauze and alcohol swabs, and the IV cannula inside. So almost all the time when I'm like so busy trying to access an IV line for a patient, I always find myself pulling the glove. I pull the glove almost all the time. And then I realize, oh my goodness, there is access. I have the tourniquet inside the pack. And then, oh, okay, I just use it. And so resource abundance is everything, is what we have right now, is what is in the US. And then you become so effective doing the nursing process because you have everything you need. When you're trying to formulate the nursing care plan, you formulate knowing that you don't have gaps in terms of supplies or the type of specific equipment that you need to give the best care. You have the vital signs machine you need. You have the patient monitor that you need. You have everything within your reach to become effective as a registered nurse. So I think also the streamlining around the scope of practice in the US is because there is always like checks and balances. If you do something that is outside your scope, then and you're taken to task about it, and it's found that you did something that you are not supposed to do, you will face litigation, and it's never going to be easy. So most healthcare providers, they are always making sure what they do is within their scope. They're always making sure that the care they're giving is not going to be outside that scope, because it's costly and you put your license online when you do something that is outside your scope. When, in the other hand, we have um, most of the clinics in many estates, like in the big cities. Some of them are owned by people who don't have certification to run services. We've seen a lot of cases in the media of people who are masquerading as healthcare providers giving care in clinics or small pharmacies, outpatient pharmacies. And then you find um, these people, because of the rule of law, they're not taken to task. They are not, even if they're taken to court, some of these cases, I mean, they're delayed, they take a long time before they can be settled. And that causes um, like loopholes for people to do what they are not supposed to do. Some of the big hospitals we have also some doctors who are actually never went to medical school. Like there's one, the case was in the media, who was practicing as a surgeon doing surgeries for 7 years, and he was never discovered until I think one of the doctors, they were having a conversation and he said that they were in the same class in the university studying medicine. Um, so you see, there are loopholes for people who are not medical practitioners to do what they are not supposed to do. But the scope in the US is so specific, and people are so, I mean, sticking to their own scope of practice. And then you see, like, the medical doctors in the US also, they have a different system of like having patients. They do either you have a doctor's office, you can practice by working, coming together and having a joint doctor's office center, or become a hospitalist in a hospital. That's what they do. But in Kenya also, you have doctors. They, so long as they're doctors and they have agreement with the hospital, they can admit patients in as many hospitals as they are able to see. So uh, when you come from a space where you have resource strained, and now being in the resource abundance space, it is very interesting to practice as a registered nurse. It's been so nice. It's been so good, and I'm hoping that at some point we will be able to share this experience, and then also now start mentorships in government Kenyan hospitals, and make friends with the people who have established healthcare centers, and share these experiences, share the standard operating procedures, and also like mentorship to make sure at least we also have our people accessing and getting the best care as we are giving care in this country. So thank you so much for joining me. I mean, I want to stop there, but I'm just kindly requesting that you guys subscribe to my YouTube channel, because I believe that this is going to be interesting for you guys. And I know that at least you get to learn something, and maybe probably you can also like do comments and ask if you have any subject or topic in healthcare that you want me to talk about also. It's gonna go or take us a long way. Thank you so much, and I believe that you're gonna have fun listening to this, and I say that I will see you next time. Thank you so much.